Hi everyone, I'm Daphne Broaders, Clinical Specialist with Medical Pharmacies. As you're likely aware, South East CCAC has been working actively for the past year and a half to optimize infusion safety. We're going to describe some changes in technologies and process that are designed to help enhance safe infusion delivery associated with the CADD Solis. The Solis was selected as it is a smart pump. It has dose error reduction software, which has an incorporated drug library designed to recognize prescription and keypad errors. There are multiple safety checks and alerts to help support correct programming and management of the pump. We know, though, that technology is not perfect, and we have to employ safeguards and strategies to optimize this. So let's look at some of these strategies. Historically, we have sent out one pump with the continuous and intermittent libraries, and another pump, the one with the purple dot, with the PCA libraries. To eliminate the need for two different pumps, one for PCA mode and one for intermittent continuous mode, and to reduce the risk of potentially receiving a pump with the wrong drug library, all Solis pumps will now have one library with both PCA and the intermittent continuous drug protocols. There is no change in practice for the nurses other than selecting the appropriate therapy, PCA, intermittent, or continuous, before selecting the appropriate protocol. The pharmacy will continue to send the pump pre-programmed in the appropriate protocol for new orders. Before we get into the drug library updates, we need to reinforce the structure of the drug library. It's crucial that anyone who's programming the pump needs to understand the design of the library to understand where and how they will find the parameters to select. First of all, the nurse selects the therapy, which in this case is PCA. You then select the qualifier. In PCA, that means the drug en route, such as hydromorphone IV or hydromorphone sub-Q. You need to choose the correct route because there's different protocols associated with the IV and the sub-Q routes. For instance, note that the intermittent mode, you no longer select the route, only the drug. For instance, in the past, you would have entered cefazolin, peripheral, or central. You no longer will be asked to select the route for intermittent protocols. Once you've selected the qualifier, you then select the drug. This is a critical point. The nurse must ensure that the correct drug and the correct concentration are selected. We've changed the way combination drugs, that is, those reservoirs which had two or more drugs, are labeled, so it's more apparent where to find them. In the past, one had to select route IV or route sub-Q to find these combination drugs. We now have the combination drugs listed as a separate qualifier. For instance, if you have a patient with bupivacaine fentanyl, the nurse would select PCA as the therapy, then combination drug by the appropriate access route. So in this case, bupivacaine fentanyl IV. As some areas may be providing epidural therapy, we have amended the intrathecal route to be labeled as epidural intrathecal drug. On your screen, you can see that we have deleted several protocols which are either no longer prescribed or we don't have stability data. What I'm about to describe is not actually a change. However, it is a key risk point in infusion safety. There have been several significant medication errors recently related to the concentration of drugs. For instance, in one case of a change in concentration, the nurse didn't change the concentration using start new protocol, same patient. Rather, he or she found a workaround, changing the rate that resulted in a significant overdose. Please ensure that all nurses who reprogram a pump for a change in concentration always go into View Advanced Tasks and then select Start New Protocol, Same Patient. You then select the appropriate therapy, in this case it would be PCA, then select the appropriate qualifier. Remember, that's the drug and the route in PCA, so in this case it's hydromorphone IV. And paying close attention, ensure that you select the correct concentration, in this case 4 milligrams per ml hydromorphone IV. Then you're prompted to double check the settings against the order and the label, and only then, if they match, press yes. It's very easy to complacently press yes. We have to reinforce that this must be an active cognitive check to make sure that the values are actually correct. Now let's look at a few of the intermittent library updates. That is primarily for most antibiotics. The default KVO rate for intermittent therapies is now 0.4 mLs per hour for both central and peripheral venous access. We were requested to make this change for another CCAC about a year and a half ago, as that was their practice, and we have not seen an increase in calls due to occlusion. Therefore, all drugs will now have a KVO of 0.4 mLs per hour, with the exception of those drugs which some call the sticky drugs, which can cause frequent downstream occlusion alarms. For drugs such as cloxacillin, Pen-G, Pip-Taz, and vancomycin, the drug library includes a higher KVO rate, with the rate being somewhere around 1.5 mLs per hour. It really is dependent on the volume of the bag. We've set it to the highest KVO rate possible, given the volume of that particular bag. Another change, which I previously mentioned, is that you no longer have to specify the route of the intermittent drug. For instance, you're not going to select peripheral versus central, as we've standardized the KVO rate. For imipenem, the pharmacy only has stability data for up to 12 hours rather than 24 hours. Therefore, the bag will need to be changed every 12 hours. This means that either the patient will need to be instructed how to perform the bag change, if appropriate, or a BID visit will be required, for instance, if the dosage is BID. CCAC is aware of this change in protocol. Also related to stability concerns, we can no longer combine cefazolin and clindamycin. These two drugs would have to be administered via 2 pumps. We recognize the implications of this change, however, we cannot safely provide these together in the absence of stability data, and again, CCAC is aware. For drugs administered in continuous mode, any drugs which are single dose, such as vancomycin Q24H, you will no longer find these drugs in the intermittent protocols. They are in continuous mode if they are a single dose drug. Another change for hydration. The pump protocol now states remove air from bag. This is a visual cue for nurses to ensure that they must remove air from bags before starting the infusion, particularly those which are prepackaged by the manufacturer and not manipulated by the pharmacy, such as your 2/3 and 1/3 or saline bags. These can contain up to 10 or 20 mils or sometimes more. So the visual cue acts as a reminder to remove that air. We're introducing the new hybrid CADD administration set, which will be used for most intermittent and continuous infusions, with the exception of PCA infusions. This is designed to reduce the number of air and line alarms. It's called a hybrid set because it's a combination of both the low and high volume sets. At the proximal end, there's a smaller bore or low volume tubing from the tubing spike all the way down to the filter. And then exiting the filter, there's a larger bore tubing. There's also a larger 1.2 micron air eliminating filter rather than the smaller 0.2 micron filter on the low volume set. The maximum infusion rate, as with the low volume set, is 250 mLs per hour. You'll also find at the distal end a needle-free luer access connector port. So you can pinch off the tubing above this injection port if you want to access it with a saline syringe and flush the catheter. There's no change in practice for nurses who use these sets, as the hybrid set latches to the pump in the same manner as the low and high volume sets that are currently used. To review, for PCA therapies, low volume sets will be used. For infusions requiring flow rates from 250 to 500 mils, a high volume set will be used. For intermittent and continuous rates less than 250 mils per hour, it will be a hybrid set that will be issued. There may be the odd intermittent drug that will be requiring a low volume set if it's a low volume drug and hence requires the smaller priming volume of the PCA set. We will indicate on the medication label which set needs to be used for that particular medication. There is a CCAC code which you can see on the screen, and as well CCAC has created a kit that has the hybrid set. So we will send out the appropriate sets. We do know that some nurses prefer to move to the high volume set, for instance, if there's been frequent occlusions. Please remember, though, that you should contact the pharmacy first if you're doing this to make sure that we don't need to make an adjustment in the rate because of the priming volume that's been added to that bag. We are excited to provide to you a medication label that has now been reconfigured to match the pump language and sequence, which helps to reduce the cognitive burden on the nurse in interpreting the label when programming the pump. The drug labels affixed to the medication bags and cassettes will now use a line to transcribe the order as written on the medication referral, mostly for the intermittent and continuous therapies, such as infuse 2 grams every 4 hours for 7 days. It'll then be followed by detailed instructions using the pump language and displaying the parameters to be programmed in the same sequence as the Solis pump. For PCA, you can see that it specifies the continuous rate, the dose, the lockout, the maximum doses per hour, and res volume. For hydration, it's written in sentence format and then indicates the rate and the reservoir volume that the pump needs to be set at. For intermittent therapies, it'll indicate the dose volume, the dose duration, the dose cycle, the KVO, the residual volume, and the type of administration set that should be used. The goal is to simplify the process of verifying the medication label. These CADD Solis updates will be implemented Monday, February the 13th. We hope that you'll experience these changes as improvements to the service provided to your staff and patients. We're now going to take just a few moments to reinforce some strategies to optimize pump safety. Please note that all nurses should be verifying the prescriber's order against the medication label and the label to the pump settings. You start from the top. So verify from the order to the medication label, do these match? Then, does the label and the pump settings, do these match? This verification is then documented on the South East CCAC infusion record or flow sheet. Record the settings from the pump onto the pump record and make sure that these match the order. For any pump programming, CCAC requires validation of pump accuracy through documenting the name of the other person that completed the independent double check or validation of accuracy and the date and time completed on the infusion record. To accomplish an independent double check, you can either call your office or colleague if they have the order, or you can send them or a colleague a screenshot of the pump settings, as there's no patient identifiers on the screen, and then read them the order so they can assess if the pump is set appropriately. Health Canada has also suggested that patients or family members may serve as a second check where appropriate. As distractions have proven to be a key risk factor in medication administration, we strongly encourage nurses to minimize distractions when managing the pump. If possible, step away from others to perform any tasks related to the pump. Inform the patient and family members that you're performing a task that requires your complete attention, and you'll speak with them in a few minutes. Then, when you're verifying the settings, you can use the Speak Aloud protocol. To do this, as you're reading the settings, Say the settings aloud. This acts as an auditory cue to others not to distract you or interrupt you, and also it acts as another sensory method to review the settings. Every shift, every nurse must verify the pump settings to ensure that the patient is receiving the medication as prescribed. When you're checking the settings in View Delivery Settings, don't forget to always check the concentration. As the concentration is written above all the other settings in that colored box, it may be easy to overlook it, which can potentially lead to an ongoing medication error. So does the concentration match the label, which you've already verified against the order? If, however, for instance, there's a pump exchange and you need to start fresh, to program the pump, you would go to Tasks, View Advanced Tasks, and Start New Patient. You then enter the therapy, the qualifier, and the protocol. Once you've entered that protocol, you'll be prompted to verify that the concentration and the drug protocol match. So take that time to go back and look at the prescription label, which you've already checked against the order, and make sure it matches the pump settings. If you're just changing the concentration of the drug for the same patient, to do that you need to go to Tasks, View Advanced Tasks, and then select Start New Protocol, Same Patient. You'll start then by choosing the therapy, then the qualifier, and then the protocol, and again you'll be prompted to confirm that concentration and drug protocol and make sure that you'd stop and check that it matches the prescription label, which matches the order. One question we received is how to indicate on the medication label if there's been a change, such as a PCA bolus dose. In discussion with the CCAC and the nursing providers, it was decided that the best approach to manage these changes that don't require a change in medication reservoirs is to cross off the incorrect value on the label. This strike through then serves as a visual cue that there's an updated order. It was suggested that the new value not be written on the cassette label or the bag label, as there may be numerous changes while that particular reservoir is in use, which can lead to confusion if you have multiple strike-throughs and numbers on it. If you only need to change some of the settings, such as the rate or the PCA dose or the dose cycle, but the actual drug or the concentration hasn't changed, there's a couple of ways to do this. You can go into Tasks, then View Delivery Settings, and make the necessary changes. But remember that when you accept those values, you're not going to be prompted to check and accept the concentration and the drug. So make sure that you stop and look at that box above that indicates the drug and the concentration to make sure that all of that matches the prescription label, which you've already verified against the order. The other way to do that is to go into Start New Protocol, Same Patient under Advanced Tasks, and there you will be forced to accept and verify the concentration and the drug protocol. We'd also like to encourage nurses who are simply changing the reservoir to refrain from using the Reset Reservoir Volume button under Tasks. This was designed to simplify the process for patients who are self-administering their therapy. However, Reset Reservoir Volume doesn't have any forcing functions to make you verify the settings. Therefore, please, when you're changing the medication bag or cassette, to change the volume, go into Tasks, then View Delivery Settings, and then Reservoir Volume to change the volume. And then you will be prompted. It will force you to accept those values and verify them against the prescription label, which you verified against the order. It's a safer way than just simply going into Reset Reservoir Volume. summarize the updates which are going to take effect Monday, February 13th. We now will be sending out only one pump, which will have all of the drug libraries on it. So you'll no longer see the pump with the blue dot and the pump with the purple dot. It's one pump for all therapies. There's a few drug library changes, which we've reviewed with you. KVO, remember, it's now been standardized, so it's 0.4 mLs per hour, except for those, what we call sticky drugs. You'll now be seeing the hybrid sets that will be used for most intermittent and continuous infusions. The maximum rate on those sets is 250 mLs per hour. We'll indicate on the label what set should be used, and we'll send out in the appropriate kit with the appropriate tubing. We've also revised those medication labels so it'll make it easier for you to verify the label against the prescription order and then against the pump as well. And don't forget, it's crucial that you always verify the delivery settings and the drug and concentration at every visit and with every pump reprogramming. We hope that these updates to the CADD Solis library and administration sets and the programming tips we've provided will help you in your safe delivery of infusion therapy. Thank you.